and I'll try and fix it. So let's see, sharing. Cool. Do you see my screen now?
Yes.
Great. I am just going to do, so I don't know that I can see the chat in this current one. So please just, if somebody can let me know if there are questions there.
Yeah.
And please do feel free to ask questions during this. This is meant to be pretty informal. I was going to go through the work that I've done around relational coordination, both at the University of Washington at the Medical Center with advanced heart failure care teams, as well as some of the more recent things that are, some are with heart failure and some are not. So, so let's see if I can make this move forward. Oh, there we go. So briefly, just wanted to acknowledge I am one person of many who have been involved in this work. So this is definitely not mine. It's more of much more of an ours, and have had collaborators at the University of Washington, at the Medical Center, at our Institute for Simulation, as well as grant team members from across the university and from community organizations. And so this work started in 2014 with a HRSA grant that was led by one of my mentors, Dr. Brenda Zeeler. We've gotten subsequently NCAT CTSA funding from looking at it from a team science perspective. And then most recently, I got first an institutional NIH K-12 Career Development Award focused on implementation science, and then most recently a K-23 from the National Heart, Lung, and Blood Institute to study this. So just wanted to sort of provide that framing as we get started. So today I'm mostly going to talk about the work that we've done with advanced heart failure care teams, and that's what Bridget had sent out, the cool visual abstract describing one of our most recent paper looking at that. And I'm going to go into that a little bit more in a moment. But that initial work with the advanced heart failure care teams has actually led to several other studies. And so one of them being the K-23 Career Development Award that I just mentioned, where I'm now going to be asking RC questions of patients and families who the patient is hospitalized with a diagnosis of advanced heart failure. A group at Johns Hopkins Hospital and the university have been adapting the model that we used at the UW, including the use of relational coordination as a baseline and follow-up survey in an inpatient stroke unit. And then most recently, Jody, and I'm less involved in this, so I can't necessarily speak to it in detail, but Jody Gattel received a grant from the Macy Foundation that will involve multiple sites, including our UW advanced heart failure care teams, and we'll be using RC in that as well. And then kind of on a little sidebar, one of my colleagues, Mayumi Wilgerote, who was involved in that initial HRSA grant, her specialty is really in school health and care coordination in schools. And so she had done a number of interviews and focus groups and realized that the framework of RC seemed really relevant to the problems that she was trying to tackle there. So we recently did a secondary analysis of qualitative data from focus groups, basically asking the question of, is relational coordination relevant in this context? And so we recently had a pilot study published from that. So that's sort of we're going to cover a bunch of different things. Any questions as we get ready to sort of hop into this? No? Okay. So this first set of slides is around our initial work with the advanced heart failure care teams at the University of Washington Medical Center. We formed an academic practice partnership between UW researchers from the schools of nursing, medicine, pharmacy, social work, and inpatient advanced heart failure care teams at one of our 3 medical centers. And the goal of this was funded by HRSA, and it was to improve team functioning and workflow efficiency and patient outcomes through team-based change management. And so we used relational coordination was written into the grant. The actual intervention that we ended up using was not written into the grant. It was basically that we would work with these teams to around facilitated change management. And so there were sort of multiple parts of this. So there were the partnerships between our academic and clinical partners, as well as some community partners. We did informed by relational coordination, did leadership training as well as simulation, and used team steps training, which I think probably a lot of you are familiar with, and then also did facilitated change management. And one of the things that we found really helpful, and I'm not sure how many of you have used this, is a set of sort of facilitation resources called Liberating Structures, to make it so that as we were having meetings and doing trainings, that they were highly interactive and not just sort of a lecture-y style of change. And so that really helped improve the way that people were working together, by creating sort of fun ways to discuss things, to address challenges, to surface ideas and things like that. So wanted to flag that because it's not necessarily called out in a lot of our RC work, but we think it had a lot to do with sort of how we actually made improvements in our relational coordination scores. When we started that initial grant, we did a bunch of baseline data collection, including initial sort of RC mapping, trying to figure out sort of who are the work groups that are involved in the care of advanced heart failure patients in the inpatient setting. We also we used the baseline RC survey, as well as a survey called the Team Steps Perception Questionnaire, and then also did clinical observations and developed a database to really just initially even think about sort of who's here, who's involved in the care of these patients. And then we used our baseline RC survey results, and our questions for the RC survey focused on basically care implementation and management for advanced heart failure patients, because we didn't have a specific intervention in mind yet when we did this. We couldn't ask specifically about rounding, which is the thing that we eventually ended up focusing on. So I think probably within this group, people are fairly familiar with the various RC domains, but you'll notice that nothing was above a 4, and there were several things that were below like 3.5, which so we had some opportunities for improvement. And this was a group that recognized that they had a lot of challenges in terms of there had been some pretty high profile within the group errors that had happened recently. And so the group was on board and recognizing that there were challenges, and they felt like the RC survey results provided a really helpful sort of validated way to formally sort of characterize what people were experiencing. And so based on those survey results and seeing what some other groups at the UW had been doing, the team decided that they wanted to implement something called structured interprofessional bedside rounds, or CIBER. So this is a rounding model that brings together 2 or more health professions with patients and families. And prior to this, the teams had been rounding either in a conference room or a hallway, so the patient and family was not there, and often the nurse or and other members of the care team were not there either. So they decided that they wanted to implement this after some of our preliminary work in the baseline RC survey. And I have a couple little slides just sort of distinguishing CIBER from other rounding models. So uniprofessional bedside rounds, where it's mostly physicians usually, or mostly nurses, hallway rounds, conference room rounds. And so CIBER is something that brings together both patients and families, as well as interprofessional care team members. And so the way that we did this, and this was at the time pretty innovative from an RC perspective, is that most of the existing RC work was sort of cross-sectional and didn't necessarily look at, if you use RC as a longitudinal measure, can you see improvements over time, or can you do things to improve RC outcomes over time? And so this is just sort of our pre-test, and then we did our CIBER intervention, and then we did annual post-tests. So we did annual RC surveys each year, and we were working with both an ICU that was focused specifically on advanced heart failure patients, a cardiac intensive care unit, and then also a step down or telemetry acute care floor. what we found, we were very pleased when doing the first annual follow-up to see pretty substantial improvements from the baseline, which is this darker gray, to the first follow-up here, which is this lighter gray, across all of the different dimensions. And we published a paper focused on that, just basically sort of describing how this purposeful interprofessional team intervention, which included formation of a change team that was comprised of frontline care team members and researchers like myself, as well as team training and simulation and changing this branding model, seemed to have a really strong impact and help improve communication relationships within this care team. And then we were really pleased to see over time, we continued working together with this team and doing sort of iterative helping to address challenges, issues with fidelity, and continued to see over the course of several years improvements. And up until I think this one was 2018, where we actually saw, so the first 2 years after implementation of cyber, we continued to see improvements. So we saw a little bit of a dip in the last year of the grant. And so that was part of why we went and sought additional funding, is we realized that a lot of the people who were filling out the survey in 2018 hadn't actually been here when we had done a lot of the training and simulation and things like that. And so we started doing additional trainings and booster trainings. And then we actually saw, oh, and I'll get to that in a second, what we found. But this is just sort of a summary of, for each of those RC domains, which ones were statistically significantly improved from baseline and which ones were not. So each of these years, it's comparing that year to the baseline year. So year 2 to the baseline, year 3 to the baseline, year 4 to the baseline. And we worked with the RC analytics folks to try and figure out how best to approach these, because this was relatively uncharted territory when we were first trying to figure out sort of how to do this analysis in an RC context. And so you'll see sort of in this year 4, we actually had a couple of things that sort of dipped back to not being statistically significantly different from the baseline, which we found concerning. And so we did do some in-person boosters. This was pre-COVID, and we then, oh, and I'll come back to this. And then we saw improvements again, and we actually, in February of 2020, which is the last time we did the survey, had the highest scores in most dimensions and overall that we had seen the entire time. We also did a number of qualitative interviews, and basically sort of our takeaway from this was that this was something that had been sustained, that there had been both culture change and work process change, and that this had become sort of the normal routine in this setting. We did in a paper that described not this 5th year, we have not published this data, but in a paper looking back at this first 4 years, that Heba, who I think spoke with this group last month, who's part of Relational Coordination Analytics, had co-authored this with me and several others. We did look at sort of variations. So what we mostly had presented was overall. So what this did is we actually wanted to see, are there changes according to work groups? So if you're a nurse on a unit, or if you're a social worker or a fellow, how is the experience of relational coordination and its change over time different? And we started sort of delving into this a little bit, and we did see some differences, as you'll see here. So the dark in each of these little mini graphs, the dark is this particular group. So like this one right here, this is the nurses in the first unit. And so at baseline, their RC was pretty low. And then it went up pretty substantially and sustained, and then dipped a little bit. And so for each of these different groups, you see sort of a slightly different pattern. And this is something that we want to address more in the future. But what we sort of, our takeaways from this, and this is the paper that got sent out, is what we think we see is that at the beginning, this is sort of the overall, there was a much broader range of different RC composite scores that each work group had, and that over time, what we saw is that they did increase for each work group, and that they did end up spreading a bit again towards the end, but that we saw this sort of narrowing and sort of more positive results rather than this whole range of people working in an environment and experiencing very different relational coordination in their work. So would love to come back to this and hear your thoughts on it. We had lots of conversations about what does this mean and what do we do with this? But we did see overall increases over time for all of these different work groups. And so from that initial work, like I was just saying, we saw positive changes in RC following this intervention that were sustained over time. Our thought on this is that these improvements seem to be largely self-reinforcing. And so we didn't, aside from some of the boosters in the final year, we didn't have large-scale team trainings or formal onboarding during those first few years. We did see that dip in the fourth year and then improvements following some booster trainings. And then we haven't had a chance to launch it completely yet, but we are in the midst of finishing up a sort of asynchronous onboarding module that's a 6 to 8 minute module that will be available to all new staff as they come on and trainees as they come on. We also saw from that, if you think back to that slide that had the little graphs on it, that some RC domains and or some groups may be more amenable to improvement and reinforcement with one-time team training or implementation of work process changes, and also that things like cyber may not address all of the RC dimensions in the same way for different work groups. But we did find that this intervention and the study design was promising for people who are trying to look at improving relational coordination, either with cyber or with other interventions. So it's a model that others can use. That we did, and I think those who've used the RC survey can attest to it, is that there is a lot of burden associated, like it's a long survey depending on how many work groups you have involved in it. And so trying to balance the annual survey burden with the benefit of the information that we were getting from it, which may not be sustainable really over the long term. And so that's part of why we haven't surveyed again since February of 2020, is that our care teams have been very busy, and we had sort of promised them that that was going to be the last one, and that was even prior to COVID. So I think with Jody's new grant, it is likely that there will be another round of the RC surveys, at least one of them, and we're really curious to see what that has to say, but also I'm curious about ways to potentially streamline or reduce the burden with RC surveys. So in terms of next steps, so I mentioned at the beginning, I recently was awarded a National Heart, Lung, and Blood Institute Career Development Award, which is a 5-year award. And what I'm looking at in that is whether higher fidelity versions of cyber are associated with better patient outcomes. And so I'm using multiple sources, including observations, questionnaires, interviews, health EHR data. And I'm continuing to use RC as a framework for this. And in that first series of studies or series of RC surveys, we did not ask questions of patients and families. That work was really focused on the care team and their relationships. And so I am adding into the questionnaires that I'm doing RC questions for patients and families, both when they're initially admitted and then after 10 days after they're discharged, about their relational coordination with the care team. And have been continuing to collaborate with Heba and Jody and the RC Analytics team to think through these and also think through analysis. The other area in which I've been using RC is with this Johns Hopkins collaboration, where they're basically adapting and implementing our intervention model and the evaluation framework, including the use of relational coordination in a stroke unit. So it's with a different population, but using that RC survey longitudinally as well, which is similar to the UW. And in a couple of slides, I'll show you sort of their baseline compared to our baseline, which is interesting. And then there's the RC in schools. So for my K-23, one of the challenges that, and I would love to get feedback on this from this group, but I've been working through this with Heba and Jody, is sort of thinking through how do you frame this when you're not asking patients and families about different work groups, and you're looking sort of at potentially comparing one point in time to another point in time. But these are sort of the questions that we've come up with that would be included along with a bunch of other questions for patients and families. So you've got both sort of the how does this, and then also after discharge, how did your team communicate with you? So this is the different, the 7 different RC domains in terms of heart failure management. So we'll be piloting these soon. And then with the Hopkins team, so the way that they framed it for their, they did their baseline survey in December 2020, January 2021. So another sort of difference in their work has been that all of this has happened during COVID, and they've actually managed to continue moving forward, which has been really impressive, because I know that a lot of inpatient improvement efforts have really had a lot of challenges over the last couple of years. And so the way that they framed their RC questions was around sort of the patient's care plan for the day. So that's a little bit different also than how we had framed it for our advanced heart failure care patients, but I think it's pretty similar. And what they found is, this is their baseline survey results. We're currently working on adapting and implementing it, writing some grants. We have one manuscript under review describing some of these baseline results, and another one more focused on RC is in the early stages of preparation, and we'll be continuing to follow up with additional surveys and data collection. But what you'll see here is interesting is that it's pretty similar to what we found, that some of them are exactly the same, which was surprising. And I'm curious to see over time as we do this in other settings where we're looking at baselines and follow-ups, whether or not this, how similar baselines are across different settings in the context of inpatient care. So, and this is sort of our baseline compared to our first follow-up. So I think there's a lot of opportunities for sort of hypothesis generation around and testing with using RC as a framework for change and improvement. So, and then the RC in schools, I briefly described that, sort of the secondary data analysis to preliminarily explore whether RC domains might be relevant in a school health and care coordination context. And so we used thematic analysis and data from this parent study that was focused on operationalization of care coordination in schools among children diagnosed with type 1 diabetes. They had done 20 focus groups with a number of different stakeholders, including school nurses, parents of children with a diagnosis of type 1 diabetes, and care providers, and then had asked participants at the beginning of those focus groups to respond to questions about care coordination. And then what we did is went back with the RC domains and coded that qualitative data. And not surprisingly, found that RC does seem to be relevant and shows up in what people are talking about when they're talking about care coordination and challenges in school health across with patients or with students and parents, as well as for like nurses within a school health context. So this project, we are still trying to sort of figure out what happens next with this. Similar to healthcare, schools have been very challenged during COVID. And so there was a grant that my colleague Mayumi was planning to submit. And then we needed to sort of put a pause on that just as the Delta surge was happening in the fall and then Omicron. So, so I think that is sort of the brief overview. I might stop sharing my slides so that I can see people a little bit again. Let's see if I can figure out how to do that. How do I? There we go. I think I stopped. Thank you. Sorry, Microsoft Teams and I are a little iffy sometimes. So would love to hear questions, comments. I can go back to particular slides too, if that's helpful.
Erin, thank you so much. I have a ton of questions, but I else wanted to before I done. Okay, I get to go. I wanted, could you pull up your slides on the questions you're going to be asking patients?
Yes. Let me go back to that.
And then, I mean, same thing for the Johns Hopkins question, right? So we're doing all this RC work with care coordination teams, and you know, it's so nebulous to just say, you know, care coordination. I like the way that you said around the patient, something that day, like. But
yeah, and that's this is the Hopkins one, and I think for this we've sort of struggled a little bit. So I think for theirs, because they know that cyber is the intervention that they're doing, and cyber focuses a lot on the plan of the care for the day, that I think this works really well. One of the things we were having a hard time with in terms of patients and families is trying to figure out sort of what's interpretable to, like, what are people going to understand at face value? I don't know if this is necessarily better, and I would love input from this group. We don't necessarily love what we have. I'll go back to, I think it's up here. What we have, what ours focused on originally was care implementation and management for advanced heart failure patients before we knew that we were going to be doing cyber. But of course, you can't then change the question over time if you're trying to compare baseline to subsequent years. So I probably wouldn't have phrased this way, knowing what I know now. But yeah, I would love to hear thoughts and comments and questions about sort of asking this question of patients and families.
Well, so you didn't change it to SIBR in the second, third, and fourth years. You kept it as care implementation. Oh wow, okay. Was that confusing for people?
I don't think so, because the point of cyber was to improve care implementation and management for advanced heart failure patients, and so we were less asking, and we did have other questions asking people about sort of their satisfaction with the model, but what we were wanting to do was improve those things regardless of what the intervention was. Does that make sense?
Totally.
Yeah.
Okay, so looking at these questions, and maybe I could, Heidi Soberg, I don't know if you want to chime in, but you know, we're working with obviously veterans who are in some way either going from hospital to community or hospital to home or home health care. You know, the next phase of this would be to talk to those patients. And so, yeah, the care team is so nebulous.
Yeah. And trying to think about, there we go. Now I can finally see you all again. Trying to figure out sort of how do you frame this for people so that they'll understand it. And we could, like, one way I was thinking about it was saying like your inpatient care team or your hospital care team. But yeah, would love to hear your thoughts.
I'm even thinking about, so Hamada's on here. His work is around you know, our centers of excellence, which are, you know, the hub and then the spokes. Yeah, I mean, I get. Is it that would you do the survey based off where you want to do the intervention? So would you say your medical team share your goals? If it's implementation work, or if it's just knowledge generation work, you would want it to be care team, but then you have to do qualitative interviews to find the gaps.
Yeah.
So you're going to go with this one for now, or the Hopkins group is going to go for this one, but then what do you do with that data?
So what the Hopkins group is doing is this one.
That one, I'm sorry. So you're going to do the, yeah.
Yeah. So they theirs has focused on the patient's plan of care for the day. And so I think for patients, we've been trying to keep it relatively similar to what we had asked the care teams about, because I would love to be able to go back and do some comparison of what have we,
gotcha.
How similar or different it is.
Okay.
Which is part of what, it was interesting when Heba was working on this with me. She sort of went through different iterations of it, of like, here's what we would originally do, and here's where we've drawn these things from. But yeah, I'm not quite certain. I might make a few tweaks to this, especially after trying it out on a few people and being like, does this make sense to you?
And are you going to do it the way Heba did it for her dissertation? Are you going to call people?
No. So the plan for this is that it's part of a REDCap survey, okay, along with a bunch of other questions about their hospitalization experience and their health status and sort of functional status and things like that.
Okay. Yeah. Yeah, I like that. I look forward to seeing what you come up with.
Me too. Yeah, so it'll be interesting to see. And I think one of the things that this will make possible is both to sort of see, do patients and families have rate these different dimensions similar to how the care team rates their communication with each other, but then also by doing this both initially when they're admitted and then 10 days after discharge, does it change over time? And so comparing from sort of that initial communication and then discharge, how they would rate communication after they've been discharged during their hospitalization. So we know that can change a lot over time.
One of the things I've had people ask me is, is any of this covered in the standard surveys that are already given to staff and patients and families?
That's a good question. I don't think in this, I think there are some aspects that are similar, but they don't get this specific in terms of, and I'm trying to think of some of the surveys that they get. There are questions that they get about sort of like, do you feel like your nurse or your physician cared about you? But I don't think that their standard questions get at any of these sort of what happened when something went wrong. Did your team know about your role that you wanted to take? One of the things that is a little bit different in how when asking these questions of patients and families that the RC folks have been doing is not trying to frame it so you're not assuming what role people would want to take. Mm-hmm. So like it's more like when you're doing it with the care teams, you're a little bit assuming that like if you're being asked this question, you have goals for the patient's care, you have work that you're doing, you have whereas this one, it's a little bit more vague almost. But that's a good question of sort of what are there other areas in which these types of questions are being asked, and at least as far as my understanding of what is being asked of our patients currently, I don't think there's a ton of overlap.
Yeah, that's interesting. So I had other questions about the SIBR, cyber, is that what you call it?
Yeah.
That's pretty standard now, isn't it, in most hospitals doing structured interdisciplinary bedside rounding?
Not necessarily. It's pretty standard in pediatrics, like where because it's very similar to like family-centered rounds. So it's at least and I am not a pediatrics person, but at least my understanding of pediatrics and the literature around it is that it's pretty common there. In ICUs, it's more common, but in sort of acute care floors, it really varies, both within academic medical centers as well as, and I think it's pretty rare in community hospitals.
Okay.
Yeah, I would agree.
Go ahead, Christine. Sorry.
Yeah, sorry. I was just coming from another meeting earlier in the hour. We used to do primarily bedside rounding at the Rocky Mountain Regional VA as our hospitalist group because we had someone who was really, really into it and advocated for it. And then Delta, Omicron, and we just realized that we couldn't go in the rooms because everybody had it. And it was dangerous for so many of us and for our patients who didn't have it yet. And then we just really haven't gotten as much back into the into the swing of things. So it's a big culture shift, and the culture ebbs and flows around bedside rounds.
Mm-hmm. Yeah, and there's a new, or not new anymore, but it's less than 3 years old, special interest group as part of the Society for Hospital Medicine around interdisciplinary and interprofessional rounds that I'm part of. And because my impression is that many hospitalists like this, and that there's sort of a difference between sort of uptake among hospitalists and more specialty groups. And so we've been primarily doing this with advanced heart failure, and we have had ebbs and flows during COVID as well. It was the norm before it, and especially in the early days of COVID, they did continue rounding as a team, but often went back to the hallway or sort of from the doorway, especially when they didn't have enough PPE or testing or things like that. And my impression from the special interest group, the SHM special interest group around this, is that a lot of groups have had similar experiences. So I am hoping that there will be sort of we'll reach some point in the next few months or a couple of years where it's like, okay, we know how to do this, and we can re-kick off cyber versions of rounds. But I do think that this has sort of caused a lot of setbacks in this area in terms of what is the norm, and also just how many family members are able to be in the hospital. Like, we've gone back and forth, and it's been for really legitimate reasons, but it's been really limited how many family members you can have there. And so I know a lot of people have been doing sort of a more intentional outreach to family members and potentially Zooming them into rounds and things like that. But since at least, I think, I'm trying to remember where we are at this point. I think you can have one person for part of the day at this point back in our system, but we've had a lot of periods of time where there's no visitors. So. Yeah.
And that's a pity that this isn't part of, the annual surveys, because man, it would be really fun to watch, maybe the dip and then the climb again.
Mm-hmm.
Yeah, the survey burden, right? This is the challenge of this stuff.
And also just tracking visitor rules. Ours was changing every week. So I think like coinciding how strict are your visitation rules right now versus how much are you doing this, right?
Yeah.
For our patients with like really advanced dementia who are nonverbal and there's no family there, I mean, certainly we'll go to bedside and, hold their hand, but like there's not that much interactive communication that can happen, around some of this.
Yeah. And I think a lot of people have gone back to the sort of more, I'll go back to this, the sort of like either hallway rounds that are either interprofessional or uniprofessional, or I don't know if you can see, I was sort of comparing cyber to other things. But yeah, I think part of what I'm hoping to see, since the groups that I'm working with have continued to use this to some extent, and in the K that I'm working on right now, in doing a bunch of observations, to be able to see sort of, for when it happens well, is it actually associated with better outcomes for patients compared to when it doesn't happen or when it happens poorly. And so we're sort of at a unique point in history for studying this, since there's been so much change since our initial work. So
timing, as usual, pretty good. So I have another question around the evaluation piece, because you mentioned that you did you did a pre-test, and then you did your intervention, and then at 1, 2, and 4 years, 3 and 4 years, you did another RC. In between there, what kind of evaluation did you do? Like, how did you know that they were, we use REAIM here in Denver. So like, were you doing REAIM assessments along the way? Yeah.
We had developed an observational tool, and this project is really what led me to become interested in implementation science and realize that I needed more training in it. So all of this was largely done prior to me having any formal implementation science training. We didn't have an implementation scientist on these grants because they were workforce development grants. And so we were doing, a colleague and I and a research assistant were doing observations along the way. And so we would bring back to these quarterly leadership workshops that we would have, usually at least twice a year, 3 times a year. We would sort of bring back updates and say, here's what we're seeing right now. Like, here's the proportion of the time that the team is in the room. Here's who's there. Here's what's happening. So I think it aligns really well with REAIM, but it's not the framework that we were using for it. And so we would bring that back, and people would talk about sort of from their perspective, what was happening, what was going well, what was where they were struggling, and then we would sort of troubleshoot how to improve it, and then continue to do observations. And so we did know, and the change teams were meeting weekly or bi-weekly during this period of time. And we had one of the sort of unique things, or it was the first time that I had seen it, was that we were able to buy out the time of one of the nurse practitioners to basically be a liaison between the grant research team and the frontline care team. So she was, the days that she was not working on research with us, she was doing frontline care. So she could always sort of say, here's sort of things that are happening and pushback that I'm getting, or things that are not working as well. And so we only did the RC survey once a year, but there was a lot of activity the entire year leading up to that.
Yeah, because when we had when we did the rural transition nurse program, and we were unknowingly doing a lot of relational coordination, we did enormous amounts of fidelity checks and data work along the way. Now with Christine's project and Heidi and Bree's projects, we don't have someone we've bought out to do the intervention, the fidelity. So it's like it's almost like a hope and pray model. Like, yeah, really want you to do this, please.
Yeah. And that's, I think, one of the things with the, with the group at Hopkins that we, that initial HRSA grant that we had was several $1 million over 4 years. And we had a lot of people and a lot of time, and that isn't necessarily scalable to other sites, or, and so that's one of the things that I'm really interested in going forward, is sort of how much of the success of our project was because of that sort of wraparound cultural intervention, versus, and the Hopkins folks have gotten some preliminary funding, and they're continuing to apply for grant funding, but it's not on that same scale. And so they've been doing observations, and I'm not quite sure exactly what month we're doing the follow-up RC survey, but I think that that's something that for these kinds of models and these kinds of interventions, that trying to figure out sort of how do you do this in ways that don't require a multi-million-dollar grant for every unit in a hospital, because we know that's not feasible. So.
Yeah, I mean, I think it's the major sticky wicket, and I keep thinking about or bring in consultants, right? That's the other option,
right?
And I mean, I know that's what a lot of people would prefer because that's how they make their careers, but that's, I mean,
yeah. Yeah, and that's, I think, thinking about sort of the different drivers of this type of change, of like, how do you make something like cyber, like in my perfect world, and like I think that it should just sort of be the standard of practice for everyone. And what I'm trying to do is sort of understand the benefits and drawbacks of this kind of model. And I think that there probably needs to be some refinement as the world has changed, as we discover the ways in which it does or does not actually improve care in the way that we are hoping it does. There is a group, I'm not sure if you're familiar with the Ipas study group, out of sort of Boston Children's. They have a very similar model of rounds that they have, that has been a part of their studies. And they found some really interesting results in terms of the impact, and they've mostly done this in a pediatric setting. So there's similarities and a lot of differences with adult advanced heart failure patients. But they've looked specifically at safety outcomes and have seen some really substantial improvements in safety. But safety is one of those things that is not well tracked in an inpatient setting. And so
the big events are so rare that you need such a huge study group. Like their big study was what, like thousands and thousands and thousands of individuals just to pick up like a couple.
Yeah.
Yeah.
And I think there, some of the sub-analysis that they've done and that a couple of other researchers have done, and I'm blanking on the name of who did this one, but is that if we're talking about sort of equity and disparities in inpatient hospital care, what they found is that it actually seems to even help more if you're working with patients who have limited English proficiency, as long as you're actually working with interpreters and incorporating them. But that the methodology that they've used around safety is a lot of family safety interviews, and sort of have added to the evidence that like patients and families know when something's going wrong. And so if we use that, but again, that's labor intensive. It's not necessarily in its current format, isn't something that you can just sort of roll into usual care to be doing sort of interviews, to be collecting that information along the way. So, yeah.
So I've been hogging all the time, and I think we could all give each other 5 minutes at the end of the hour, just maybe to before we move on to the next. Does anyone else have any questions or comments for Erin, who I so appreciate you taking the time?
This is interesting work.
Thank you.
So you have a really nice story with the changes over time. I know Heba and some of you have discussed using the network, the nature of the network as a kind of point of analysis and describing that. Is that something you guys have been discussing? It might not be wise, given how clean your story is right now, to introduce that whole literally web of problems.
Yeah, can you say a little bit more about sort of what you're thinking in that area?
So using social network analysis, where the nodes are the team members, or any of the patients and families, so forth and so on, all the stakeholders, and the edges are actually the RC scores. And you can look at different RC scores or total RC scores, and even threshold it, so you can actually show the relationships visually, as well as do some analysis quantitatively with a more network analysis.
Yeah, I think that it would make a lot of sense to do. It is definitely not my area of analytic expertise, but I think that it would add a whole nother sort of dimension to it, and that could be really interesting, especially if you're talking about sustainability or sort of barriers and facilitators to these kinds of changes. So I think it would be really interesting, and we've shared our data with others before, and would be happy to do it again if there's somebody that wants to do this kind of analysis with our data, or would want to partner with us on it. Because I think thinking in my limited understanding of network analysis, but like thinking about sort of how does it change over time, and what can you do to sort of identify an area and then try and actually have it look different the next time, I think could be really interesting. But that's not something at this point that we've done. But I would love to see either Heba or others sort of delve into this, because I do think that there's a lot of potential for additional RC analysis that hasn't happened yet, just because it's still so relatively new.
All right, thanks.
Yeah.
Congratulations on such cool work.
Yeah, no, it's been definitely a privilege to collaborate with folks on this, and to see such really stark improvements that you don't usually see, or that are hard to, you never know if they're going to actually happen or not. So I think I stopped sharing my slides. I don't know if others have questions or comments, or if there's any other housekeeping that you have for next time. So.
Yeah, this is super interesting, and it's right just ahead of where we're hoping to go with some of the stuff we're doing in Denver. So I really appreciate you sharing it all with us.
Yeah, no, and I appreciate getting to join these things and sort of think about and hear about what others are doing with this. I think the reason that I keep using it is that it seems to work well. Like it does a good job of describing the challenges that we're trying to address, and is specific enough and also approachable enough that it has a lot of face validity for lots of different stakeholders. And so we found it to be a really useful framework, and I'm sort of interested to see sort of where some of these things go next. So.
Well, and I love that you published it, right? There's a lot of work going on, but they're all being done by consultants who don't share, and that just makes the work harder. So I love that you're in the academic world and you're publishing and sharing it broadly. So we appreciate it.
Yeah, and I think some of the changes in how, like I know that Jody and that team have been continually trying to figure out sort of how do you license this, how do you share this, and it seems like it's getting easier and more accessible, especially if you don't necessarily have a huge budget, which my K definitely does not have a huge budget, a little budget, to be able to use these kinds of things. So I think that'll help. So.
Well, congratulations on the K. That is awesome.
Yes, very excited. So.
Yeah. So should we get 4 minutes of our world to turn over?
Yeah, sounds good.
Thank you, Erin. That was amazing.
Thanks,
I really appreciate it.
Yeah, nice to see you all. Bye.
Bye.
Hi, everyone.
Thank you.